Pulmonology. Condition: obstructive airway diseases. Bronchial asthma. Background: about 2.7 million Australian have asthma, with the prevalence higher among the indigenous people. No longer considered as a single disease, but a heterogeneous group classified according to phenotypes. Roles of general practitioners in asthma management: assessment and diagnosis, prescription of regular medications, education including device use and adherence to preventer medicines, provision of written action plans, regular review, management of acute asthma attacks, management of comorbidities and addressing lifestyle factors. Majority of asthma cases will not require referral to a specialist. One of the important causes of asthma hospitalization is the suboptimal use of SABA. Clinical features. Findings that are compatible with asthma include more than one of wheezing, breathlessness, chest tightness, and cough as symptoms. Symptoms that are recurrent or seasonal. Symptoms that are worse at night or in the early morning. History of allergies, example allergic rhinitis, atopic dermatitis. Symptoms obviously triggered by exercise, cold air, irritants, medicines, example aspirin or beta blockers, allergies, viral infections, laughter. Family history of asthma or allergies. Symptoms began in childhood. Widespread wheezes audible on chest auscultation. FEV1 or PEF lower than predicted without other explanation. Eosinophilia or raised blood IgE level without other explanation. Symptoms rapidly relieved by a SABA. Diagnosis. Please refer to the Australian Asthma Handbook, see resource folder. Management. Please refer to the Australian Asthma Handbook, see resource folder. Key points. Asthma is defined clinically as the combination of variable respiratory symptoms and excessive variation in lung function. Asthma is not a single disease, and this may explain the spectra of responses to various medications. Spirometry, pre- and post-bronchodilator, should be performed in all patients with suspected asthma. Airway obstruction is defined as FEV1/FVC ratio of NLT 0.7. Reversibility is defined as an increase in FEV1 of superscript 3 200 ml and superscript 3 12% from baseline. A normal spirometry does not rule out asthma and may require lung volume studies, PEF monitoring, and documenting variability for 2 weeks. Repeat spirometry when symptomatic, performing bronchial provocation testing, or follow-up spirometry after a trial of inhaled corticosteroids. The stepwise approach to asthma management aims to establish the lowest dose of therapy that can control a patient's symptoms. Step 1, as required therapy, with as required SABA or as required ICS plus formoterol. Step 2, with regular daily low-dose ICS plus as required SABA or as required low-dose ICS plus formoterol. Step 3, with regular daily low-dose ICS plus labo plus as required SABA or regular daily low-dose ICS plus formoterol plus as required low-dose ICS plus formoterol. Step 4, regular daily medium-dose ICS plus labo plus as required SABA or regular daily medium-dose ICS plus formoterol plus as required low-dose ICS plus formoterol. Consideration for specialist referral and addition of shiotropium while awaiting referral. Step 5 requires specialist assessment and consideration of additional therapies for severe asthma, consideration for high-dose ICS plus LABA or addition of shiotropium awaiting specialist referral. Inhaler technique and confounders should be evaluated and managed before stepping up treatment. Nebulization has no advantage over metered dose inhalers in patients who can use the latter. A metered dose inhaler used with a spacer will have better delivery of medication than a metered dose inhaler alone, regardless of inhaler technique. Management of asthma exacerbation requires rapid severity assessment. SABA should be used optimally, up to 12 puffs of 100 mg per actuation at a time for severe exacerbation or 2-5 mg continuous nebulization for a life-threatening exacerbation. Systemic corticosteroids, prednisolone 37.5 to 50 mg orally continued daily for 5 to 10 days, or hydrocortisone 100 mg for every 6 hours until oral medication is tolerated, should be started within the first hour. Add-on treatment including ipratropium and magnesium may be used based on the algorithm. A patient with signs of respiratory failure should be admitted to the intensive care unit and hooked to invasive airway support if required. All patients should have an asthma action plan that is regularly reviewed in general practice. Chronic obstructive pulmonary disease. Background. A chronic, progressive disease characterized by persistent airflow limitation resulting in a combination of small airway disease and parenchymal lung disease. Tobacco smoking is the most important risk factor, although any noxious particles, dusts, gases, or uncontrolled asthma, airway remodeling, can lead to COPD, high index of suspicion according to occupational exposure. Clinical features. Considered in all patients and GT 35 years of age with symptoms such as breathlessness, cough, recurrent respiratory tract infection, wheezing and/or sputum production, and a history of exposure to risk factors. Symptoms typically appear at a much later age, thus, early onset and rapidly progressive COPD should consider the possibility of alpha-1 antitrypsin deficiency. Key points. COPD is diagnosed by spirometry. Post-bronchodilator FEV1/FVC and LT 0.70 confirms persistent airflow limitation. This lack of or partial reversibility differentiates it from asthma. Lung volume studies may help reinforce the diagnosis and would typically show increased total lung capacity and residual volume. DLCO may be reduced depending on the degree of parenchymal lung involvement but is not as pronounced as in diffuse parenchymal, interstitial, lung disease. Borderline spirometry should be interpreted with caution with consideration of alternative diagnoses. Although used as a reference, the GOLD rubrics model is not explicitly relied on as a basis of classifying and managing COPD in Australia but a subjective assessment of the symptom control. MMRC dyspnoea scale and CAT assessment are not routinely used to assess the degree of symptoms. FEV1 as a measure of severity has been removed due to its lack of precision. The three interventions proven to have a mortality benefit for COPD include smoking cessation, long-term oxygen therapy, and lung volume reduction surgery. For chronic smokers, referral to quitline is the minimum intervention. Pharmacologic treatment improves the quality of life and starts with as needed SABA or SAMA, then subsequently stepped up with LABA or LAMA or LABA plus LAMA, LABA plus LAMA plus ICS. The and LT 50% threshold for FEV1 requirement for initiating triple combination has already been removed. Inhaler technique should always be reviewed. All COPD patients should have a GP management plan and COPD action plan. Pulmonary rehabilitation should be optimized early in all exercise-limited patients, especially if FEV1 is and LT 50%. All COPD patients should have annual seasonal influenza immunization, COVID-19 immunization, and pneumococcal immunization according to the guidelines. Comorbidities should be proactively identified and managed, from the previous wording of considered, since multimorbidity is the rule, and death is most often due to non-respiratory causes, usually cardiac. Prevention of exacerbation is central to COPD management due to the resulting decline in lung function. The three important components of COPD exacerbation management are systemic corticosteroids, 5 days is usually sufficient, antibiotic therapy, and SABA, with oxygen supplementation if required, and LT 88% by oximetry. Bronchiectasis. Background. Irreversible pathologic dilatation of the bronchi or bronchioles, focal or diffuse, resulting from an infectious process occurring in the context of airway obstruction, impaired drainage, or abnormality in antimicrobial defenses. Causes include congenital, cystic fibrosis, which primarily involves the upper lobes, and primary ciliary dyskinesia, infections, tuberculosis which preferentially affects the mid-lung fields and allergic bronchopulmonary aspergillosis which predominantly affect the upper lobes, inhalation, aspiration, smoke, traction, nonspecific interstitial pneumonia, asbestosis, radiation, and systemic inflammatory or immunologic disorders, rheumatoid arthritis, systemic lupus erythematosus, scleroderma, sarcoidosis. Clinical features. Signs and symptoms include chronic cough with purulent sputum, wheezing and slash or crackles, mild to moderate airflow obstruction, and digital clubbing. Diagnosis. High-resolution computed tomography is the gold standard for the diagnosis. The presence and degree of airflow obstruction should be documented by spirometry. Possible etiology should be investigated on. If an underlying cause is not evident, investigations may include serum full blood count with differential, serum total IgE, specific IgG, and IgE to Aspergillus, with or without Aspergillus skin prick testing, serum IgG, IgM, and IgA, sputum culture and susceptibility testing, including testing for mycobacteria, sweat chloride test for cystic fibrosis, screening for autoimmune disorders. Management. Main objectives of bronchiectasis management are improvement of symptoms and quality of life, minimize exacerbations, limit disease progression. Essential elements of management: exercise and pulmonary rehabilitation. Ideally referred to pulmonary rehabilitation service for a program on maintaining normal weight, muscle strength, and muscle mass. Airway clearance. Ideally referred to a respiratory physiotherapist for an airway clearance program. General measures, example developing action plans, smoking cessation, immunization, nutrition, managing causes and comorbidities, spirometry testing. Treating infective exacerbations, i.e., antibiotics, bronchodilators. Long-term oral or inhaled therapy, usually with a low-dose macrolide, anti-inflammatory property, may be used to reduce exacerbation frequency in patients with NGT3 exacerbations when all other aspects of management has been optimized. Managing hemoptysis. Investigations may include computed tomography with angiography, selective bronchial artery angiography and bronchoscopy with possible bronchial artery embolization or lobectomy. Bronchodilators and corticosteroids are used only during periods of exacerbation or when there are other indications for its use, example asthma, COPD. Reasons for referral to a respiratory physician include rapid progression of disease symptoms, disease requiring hospitalization, severe respiratory symptoms, lack of response to treatment, recurrent exacerbations, and GT3 per year. Resistant or unusual organisms isolated in sputum, example nontuberculous mycobacteria, Pseudomonas aeruginosa. Hemoptysis. Condition: diffuse parenchymal lung diseases. Background: characterized by varying degrees of inflammation and fibrosis. Diffuse parenchymal lung disease is preferred over interstitial lung disease due to the widespread affectation of the airways, parenchyma, and vasculature. May be due to connective tissue diseases, example systemic sclerosis, rheumatoid arthritis, systemic lupus erythematosus, polymyositis, dermatomyositis, occupational or environmental exposure, example asbestosis, silicosis, hypersensitivity pneumonitis, respiratory bronchiolitis, interstitial lung disease, DIP, medications, example amiodarone, nitrofurantoin, methotrexate, bleomycin, radiation, primary lung disease, example sarcoidosis, lymphangioliomyomatosis, or idiopathic, example cryptogenic. Organizing pneumonia, acute interstitial pneumonitis, idiopathic pulmonary fibrosis, nonspecific interstitial pneumonia. Clinical features. Patients present with nonspecific symptoms such as dyspnea and dry cough, resulting into a delayed diagnosis. Crackles, fine, Velcro-like, squeaks or squawks, short duration, high-pitched sounds similar to a wheeze, skin and musculoskeletal signs, i.e., if secondary to a rheumatologic disease, premature graying of hair, example short telomere syndromes, familial interstitial lung disease, and clubbing of the digits may be appreciated, the latter being more common in diffuse parenchymal lung diseases than in obstructive airway diseases. Diagnosis. Imaging plays an important role in the diagnosis of suspected diffuse parenchymal lung diseases. Chest radiography. Non-revealing in the early stages, but may be helpful in ruling out other causes of dyspnoea. High-resolution computed tomography. Imaging of choice and biopsy sparing. The pattern and distribution characterize the various diffuse parenchymal lung diseases. Upper zone predominant diseases include sarcoidosis and chronic hypersensitivity pneumonia. Lower zone distribution diseases include idiopathic pulmonary fibrosis and nonspecific interstitial pneumonia. Usual interstitial pneumonia pattern is the term used to describe a specific pattern on computed tomography and is characterized by honeycombing, with or without traction bronchiectasis. Subpleural, basal predominant reticulation. Absence of or minimal ground glass opacity. Absence of nodules, cysts, and other features, example pleural plagues. Histological features of usual interstitial pneumonia pattern include marked fibrosis and honeycombing in a subpleural distribution, patchy involvement of lung parenchyma with fibrosis, presence of fibroblastic foci. Nonspecific interstitial pneumonia pattern is oftentimes seen in connective tissue diseases, drug-induced causes, and unknown causes, usually observed with bilateral, often lower zone ground glass opacities with reticular changes, with or without traction bronchiectasis. Pulmonary function testing, usually with restrictive pattern, that is, parallel decrease in FEV1 and FVC and a relatively preserved FEV1/FVC ratio. DLCO is reduced. TLC and RV are reduced. Blood tests. Appropriate tests are directed towards the suspected underlying cause. Management. Idiopathic pulmonary fibrosis. Background. Chronic, progressive fibrosing lung disease typically occurring in elderly, and GT 65 years, males with a history of smoking. Untreated idiopathic pulmonary fibrosis has a prognosis of 3 to 5 years. Clinical features. Progressive dyspnoea and cough with deteriorating pulmonary function. Diagnosis. The diagnosis requires the following. High-resolution computed tomography findings of usual interstitial pneumonia pattern. Exclusion of potential secondary causes. Correlation of clinical, radiological, and pathological findings, if with biopsy but not usually performed due to the high specificity of the imaging findings, with a multidisciplinary team. Treatment. Available medications in Australia are nintedanib and pirfenidone, but are not curable and would only slow progression of mild to moderate disease. Prednisolone, azathioprine and N-acetylcysteine combination is no longer recommended. Other interventions that may be useful include smoking cessation, pulmonary rehabilitation, medications for symptom control, long-term oxygen therapy if hypoxemic, early referral for lung transplantation, referral to palliative care team for improvement of quality of life including symptom control, psychological care, and advanced care planning. There are no proven therapeutic options for exacerbations, but corticosteroid therapy can be trialed. Nonspecific interstitial pneumonia. Background. Preferentially affects younger patients and is strongly associated with connective tissue diseases, most commonly systemic sclerosis but also rheumatoid arthritis, systemic lupus erythematosus, polymyositis or dermatomyositis, and undifferentiated connective tissue disease. Have a high index of suspicion in young patients diagnosed with a diffuse parenchymal lung disease at a young age, and LT 50 years, especially if female. Prognosis is better than idiopathic pulmonary fibrosis. Clinical features. Initially manifests with nonspecific pulmonary signs and symptoms, i.e., idiopathic nonspecific interstitial pneumonia, with signs and symptoms of the underlying connective tissue disease manifesting later, example skin thickening, rash, and arthritis. Diagnosis: serologic, predominantly affecting the lower lobes, like idiopathic pulmonary fibrosis. Serologic markers for the underlying, suspected connective tissue disease, example anti-SCL70 antibody for systemic sclerosis. Management: evidence supports the use of immunosuppressants or immunomodulators in patients with scleroderma, but not much for nonspecific interstitial pneumonia due to other causes. Cryptogenic organizing pneumonia. Background: patchy process that involves proliferation of granulation tissue within alveolar ducts, alveolar spaces, and surrounding areas of chronic inflammation. There are many causes of this pattern, including acute infections, oftentimes treated initially as community-acquired pneumonia, and autoimmune disorders. Thus, the terminology is reserved for the idiopathic variant. Clinical features: the signs and symptoms mimic that of community-acquired pneumonia developing over a period of 6 to 8 weeks. Diagnosis: it's reasonable to consider and treat this condition initially as community-acquired pneumonia, but failure to respond to appropriate antibiotics should raise the suspicion for an alternative diagnosis. Typically presents with bilateral diffuse alveolar opacities on chest radiography with or without multiple peripherally located large nodules. Pulmonary function test is oftentimes normal. Management: good response to systemic corticosteroid with a favorable overall prognosis. Acute interstitial pneumonia. Background: idiopathic, uncommon form of diffuse lung injury that develops over days to weeks. Clinical features: signs and symptoms like acute respiratory distress syndrome, i.e., severe and progressive hypoxemia. Diagnosis: imaging will show diffuse bilateral airspace opacification. Management: treatment is mainly with corticosteroids and supportive care, but the mortality rate remains high. Sarcoidosis. Background: an idiopathic multi-organ inflammatory disease characterized by tissue infiltration by mononuclear phagocytes, lymphocytes, and non-caseating granulomas. Clinical features: majority has pulmonary involvement. Nonspecific signs and symptoms including fatigue, dyspnea, and or cough. Diagnosis: diagnosis of exclusion confirmed by tissue biopsy except for classic clinical presentations of known sarcoid syndromes, namely, Löfgren syndrome, hilar lymphadenopathy, acute oligoarthritis and erythema nodosum, and Hereford syndrome, uveitis, parotid gland enlargement, and fever. Often an incidental finding on chest radiography as bilateral hilar lymphadenopathy. Management: spontaneous resolution is the rule. Bilateral hilar lymphadenopathy alone doesn't need treatment, 3 to 6 months monitoring preferred over corticosteroid therapy. Acute sarcoidosis is treated with bed rest and nonsteroidal anti-inflammatory drugs. Corticosteroids are first line if with significant morbidity, i.e., parenchymal lung disease, uveitis, hypercalcemia, and neurological or cardiac involvement. Prednisolone 40 mg orally daily for 4 to 6 weeks, then tapered over a year according to clinical status. 4-methylprednisolone and immunosuppressants, example methotrexate, hydroxychloroquine, cyclosporin, cyclophosphamide, are reserved for severe cases. Anti-tumor necrosis factor or lung transplantation may be considered in refractory cases. Hypersensitivity pneumonitis. Background: immunologic response to repetitive inhalation of antigens, most commonly from thermophilic actinomyces, fungi, and bird droppings. Has an acute, subacute, and chronic forms. Clinical features: the acute form develops after 48 hours of significant exposure from responsible antigens and is associated with constitutional signs and symptoms including fever, cough, myalgia, arthralgia, and shortness of breath. The subacute and chronic forms occur over long periods of low-level exposure to responsible antigens. Bird fancier's disease is the most notable example, and manifest with cough, dyspnoea, malaise, and weight loss. Diagnosis. On high-resolution computed tomography, the acute and chronic forms will manifest with ground glass opacities and centrilobular micronodules with middle to upper lung predominance, with evidence of septal line thickening and fibrosis with the latter. Management. The primary treatment is removal from exposure. Corticosteroids are reserved for patients with severe symptoms and evidence of fibrosis. Condition: occupational lung diseases. Asbestosis. Background: always consider if the occupational history is related to any of automotive, construction, mining, or shipbuilding industries. The temporal pattern from period of exposure to disease development is 15 to 35 years. May affect the lung parenchyma, i.e., obstructive airway disease, diffuse parenchymal lung disease or cancer, and the pleura, i.e., pleural plagues, pleural fibrosis, benign pleural effusion, or malignant mesothelioma. Clinical features. Nonspecific signs and symptoms including shortness of breath, persistent cough, fatigue, wheezing, and chest or back pain. Diagnosis. Parietal plagues are the most common finding on imaging. Pleural effusion, either benign or malignant, may be observed. Pulmonary function testing often reveals a restrictive pattern. Pleural fluid cytology has a very low yield in the diagnosis of malignant mesothelioma, thus, pleural biopsy is preferred. Management. Prevention is the most important aspect of management. Symptomatic treatment, i.e., inhaled bronchodilators, appropriate antibiotics, oxygen supplementation if hypoxemic. Transplantation may also be considered. Silicosis. Background. Most often results from exposure to crystalline silica, example manufacturing of artificial stone bench tops. The spectrum of manifestations ranges from asymptomatic, multiple small pulmonary nodules and calcified lymph nodes, through to progressive massive fibrosis. May be accelerated, 3 to 10 years after exposure, or latent, and GT 10 years after exposure. Risk of pulmonary tuberculosis is increased, and so as with lung cancer. Clinical features. Nonspecific signs and symptoms like asbestosis initially. Diagnosis. Imaging may show upper lobe predominant small pulmonary nodules, simple silicosis, to progressive massive fibrosis. Management. Same principle with asbestosis. Condition: pleural diseases. Pleural effusion. Background: most common disorder affecting the pleura. Can either be transudative, i.e., cardiac, hepatic, or renal cause, or exudative, example malignancy, hemorrhage, parapneumonic effusions, tuberculosis, autoimmune diseases, pancreatitis. Clinical features. May present with shortness of breath, pleuritic chest pain, and signs and symptoms of the underlying cause. Diagnosis. The first step is to determine whether the pleural effusion is exudative or transudative after an ultrasound-guided diagnostic thoracentesis using a gauge 21 needle, can be safely performed at bedside. The Lights criteria helps distinguish a transudative from an exudative effusion, any of three. Pleural fluid total protein/serum total protein and GT 0.5. Pleural fluid LDH/serum LDH and GT 0.6. Pleural fluid LDH and GT 2/3, the upper limit of normal for serum LDH. Management. Parapneumonic effusion and empyema. Significant effusions, defined by a depth of NGT 1 cm on lateral decubitus X-ray or NGT 3 cm on chest CT scan, and/or dyspnoea, requires diagnostic thoracentesis. Indications for drainage include persistent fever and systemic signs of infection despite adequate antibiotic therapy. Large size, and GT 1/3 of the hemithorax. Loculated effusions. Evidence of continued pleural infection such as frankly purulent or turbid fluid on sampling. Presence of bacteria on gram stain or culture of pleural fluid. Pleural fluid pH and LT 7.2. Pleural fluid lactate dehydrogenase and GT 1000 units/L. Empyema. For small parapneumonic effusions, no change in the community-acquired pneumonia regimen is necessary. For large parapneumonic effusion or empyema with low to moderate severity disease, the antibiotic regimen is a combination of benzyl penicillin 1.2 g for every 6 hours plus metronidazole 500 mg for every 12 hours. If with immediate non-severe or delayed non-severe penicillin allergy, an alternative is ceftriaxone 2 g for daily or cefotaxime 2 g for every 8 hours plus metronidazole 500 mg for every 12 hours. If with immediate severe or delayed severe penicillin allergy, an alternative is moxifloxacin 400 mg for daily. For large parapneumonic effusion or empyema with high severity disease, the antibiotic regime is similar to low to moderate severity disease except that the frequency of cefotaxime may be increased to 6 hours. A typical step down is with amoxicillin 1 g orally every 8 hours plus metronidazole 400 mg orally every 12 hours. If single drug therapy is preferred, amoxicillin plus clavulanate 1 g orally every 12 hours. If with immediate non-severe or delayed non-severe penicillin allergy, an alternative is cefuroxime 500 mg orally every 12 hours plus metronidazole 400 mg orally every 12 hours. If with immediate severe or delayed severe penicillin allergy, an alternative is moxifloxacin 400 mg orally. The duration of antibiotic treatment is usually 3 to 4 weeks including step-down therapy. Intrapleural enzyme therapy with alteplase 10 mg plus dornase alpha 5 mg in 50 ml normal saline solution injected via an intercostal tube twice a day for 3 days has also been shown to reduce hospital stay and the need for surgery. Surgery is reserved if all previously mentioned measures fail. Malignant pleural effusion. For a patient with suspected malignant pleural effusion, an initial negative diagnostic thoracentesis requires a repeat thoracentesis, additional yield that have a diagnostic and prognostication value. Malignant pleural effusion confers a poor prognosis. Fluid reaccumulation is typically the norm after initial drainage, thus, managed with pleurodesis or placement of a permanent indwelling pleural catheter. Pneumothorax. BAC, defined as the presence of air in the pleural cavity. Classification. Spontaneous pneumothorax. No precipitating events. Classification. Primary spontaneous pneumothorax. No underlying pulmonary disease. Recurrence rate is 30 to 50%. Secondary spontaneous pneumothorax. With underlying pulmonary disease, example chronic obstructive pulmonary disease, asthma, diffuse parenchymal lung disease, or cystic fibrosis. Traumatic pneumothorax. Caused by blunt or penetrating chest trauma. Clinical features. The classic clinical context of spontaneous pneumothorax is sudden onset of dyspnoea and pleuritic chest pain in a thin young man. Secondary and traumatic pneumothorax will have a similar presentation with spontaneous pneumothorax but with a relatively clearer causal relationship. Signs include absent breath sounds, tachypnoea, decreased chest wall movement, hyperresonance to percussion, decreased vocal resonance and tracheal deviation to the opposite side, same side with atelectasis. Tension pneumothorax is a medical emergency and requires a high index of suspicion, that is, progressive breathlessness associated with paradoxical breathing, muffled heart sounds, raised JVP, and hypotension. Diagnosis. Chest X-ray is sensitive in the diagnosis of pneumothorax, but is not a requisite and should not preclude emergency management of a likely tension pneumothorax. Management. Refer to the algorithm below, but the principles and general steps in management are: primary spontaneous pneumothorax. Document by chest X-ray or CT. Provide adequate pain relief and oxygen support, if hypoxemic. Assess for any signs of hemodynamic instability, i.e., hypotension, tachycardia, tachypnea, hypoxemia, severe symptoms. If no, may be observed for 4 hours. If yes, aspirate the pneumothorax. Tension, decompensated, pneumothorax requires needle decompression. The cannula is inserted above the third rib in the midclavicular line followed by insertion of a thoracostomy tube. Refer to surgery lecture for catheter aspiration and intercostal catheter drainage. Discharge if the patient remains stable or has improved after aspiration, and admit if in the contrary. Recurrence of pneumothorax in the same lung requires pleurodesis due to the steep rise in subsequent recurrence rates. Secondary spontaneous pneumothorax. Same principles in management. Primary spontaneous pneumothorax, except that these patients are likely to require admission and insertion of an intercostal chest catheter. Figure 1. Management of pneumothorax. Condition, pulmonary hypertension. Background, defined by resting mean pulmonary artery pressure of superscript 325 mmHg. In pulmonary artery hypertension, the disease is localized to small pulmonary arterioles, category 1. Category 2 to 5 symptoms are off. Category 2 to 5 pulmonary hypertension are caused by a known secondary cause. Clinical features. Symptoms are often nonspecific but typically progressive dyspnea and fatigue. If the underlying etiology is secondary, the patient will present with other signs and symptoms of said cause, example heart failure, chronic obstructive pulmonary disease. Diagnosis. Initial investigation is typically with echocardiography. Right heart catheterization is performed if echocardiography is unrevealing, but is required in pulmonary artery hypertension. Confirmation of pulmonary hemodynamics, determination of response to vasodilator infusion. Confirmation of pulmonary hypertension is followed by investigations for the underlying cause, unless already known. Exercise testing is usually performed prior to treatment to determine the degree of functional impairment, which will serve as baseline with which to compare therapeutic response. Management. Treatment of pulmonary hypertension due to a known cause is directed at the underlying cause, example optimal pharmacologic treatment of heart failure, oxygen supplementation in chronic obstructive pulmonary disease patients with hypsemia, anticoagulation in patients with chronic thromboembolic pulmonary hypertension. Treatment, not cure, of pulmonary artery hypertension include calcium channel blockers in patients with acute vasodilator response at catheterization, i.e., a decrease in mean pulmonary artery pressure of at least 10 mm Hg without significant reductions in cardiac output or systemic blood pressure. Prostanoids, example epoprostenol, treprostinil, eloprost, is a vasodilator group with anti-smooth muscle proliferative properties. Endothelin 1 receptor antagonists, example bosentan, ambrisentan, block the action of endogenous vasoconstrictor and smooth muscle mitogen endothelin. Phosphodiesterase 5 inhibitors, example sildenafil, tadalafil, prolongs the effect of intrinsic vasodilator cyclic GMP by inhibiting hydrolysis of phosphodiesterase 5. Oral medications, example phosphodiesterase 5 inhibitors, endothelin 1 receptor antagonists, are generally preferred initially over the parenteral, example epoprostenol, and inhaled, example iloprost, medications. Condition: pulmonary nodules and lung cancer. Pulmonary nodule basic definitions and approach. A solitary pulmonary nodule refers to a lesion and LT3-CM and may be caused by malignancy or benign tumors, example granuloma, hamartoma, vascular malformation. A subcentimeter nodule refers to a nodule and LT8 mm. For patients presenting with an incidental finding of pulmonary nodule on imaging, review of previous imaging is the most appropriate initial approach. The evaluation of a subcentimeter nodule depends on the risk or pretest probability of lung cancer. Parameters typically include age, and GT 50 years, smoking history, diagnosis of chronic obstructive pulmonary disease, environmental and radiation exposures, and family history. In general, patients with a stable pulmonary nodule over the next 24 months, except those with ground glass opacities which may represent a slow-growing carcinoma and arbitrarily requires 5 years of monitoring, does not require further testing. Low-dose chest CT scan is the preferred imaging for monitoring pulmonary nodules. The schedule of pulmonary nodule monitoring depends on the Fleischner criteria, the British Thoracic Society guidelines, or American College of Chest Physicians guidelines. Figure 1. Fleischner criteria for surveillance imaging of subcentimeter solitary solid pulmonary nodules. Figure 2. Management recommendations for solitary pulmonary nodules ranging from greater than 8 mm to less than 30 mm. Lung cancer, please refer to Optimal Care Pathway for People with Lung Cancer in Resource folder.